Hello and welcome to West Wind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find West Wind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. I'm very happy to be here today with Dr. Benjamin Besse, who is a medical oncologist and the head of the thoracic oncology program at the Institut Gustave Roussy in Villejuif, France, right in Paris. Thanks so much for taking the time today.
Thank you, Jack.
We're here at the World Conference on Lung Cancer in Barcelona, and I don't get a lot of opportunities to talk with luminaries from other parts of the world, so this is great. Why don't we just start with your background? Did you grow up, were you born and raised in the Paris, France area?
I was born in Paris. I was raised there. My family background is mostly musicians. So I'm, among all my cousins, I'm the only one, I'm the black sheep, and the only doctor of the family, which is very good, in fact, because there is no internal,
competition.
Yes. I'm not trying to kill my father being a doctor like he was.
But so when did you develop this interest in medicine? And clearly it wasn't from a family expectation of you going into the field.
Well, it was, I guess for most of us, it becomes obvious that this is something that you want to see. I probably always knew that, but it's really at the very, very last minute that I said, well, I will try medicine. It was not something at 10 years old, I didn't say, I want to be a physician. It was probably there, but it's really when I was just before university that I decided to try medicine. And then for oncology, it was my very, very first, when I put the first foot in the hospital, so I think it was in second year, it was for a 2-week stay with the nurses. We used to begin like that. And when we went to the hospital, there were like, I don't know, maybe 20 students, and most of them wanted to go to internal medicine because it's so hard to go to internal medicine, and I had absolutely no idea where I would stay. So everybody said, I want to go there, I want to go to the ICU, and so on. And I was like, well, I don't know. And the two last options were psychiatry and medical oncology. Nobody wanted to go there because it was, cancer. It was 99. And then I said, well, I will go to medical oncology. And I said, and it was fantastic. And I said, I saw this guy prescribing chemo that can kill if you don't give the good dose, and mixing, the chemo, and I said, this is what I want to do.
That's great. Now, you decided to do a PhD, correct?
Yes.
How common is that here? That's not necessary in going into oncology?
No,
so what was your motivation?
It's really an option. Well, my view, but it's a general view in life, is that I don't want to close doors for future opportunity. So I don't know exactly what I will do in 5 years, but I know that if I want to do something and I don't have the background to do it, I will be frustrated. So I embarked in a PhD so that I was sure that I would not miss a future opportunity. And of course, because it's a fantastic opportunity to see something else and learn all the weaknesses of translational research. Because when you are in the lab and you see how weak are some results, then you have a different view on all these hot papers and say, well. And the beautiful thing also is that I stayed 1 year away from France and I came in Barcelona. So I stayed 1 year in Barcelona.
In a lab then?
In a lab, in Raphael Rosel's lab.
Wow.
Fantastic experience. It was at the time of ERCC1 and all this chemotherapy link biomarker, and so this city is very special for me. I like very much this city.
Yeah, it's interesting. I wonder if Parisians can appreciate the food and the lifestyle of Barcelona, which is a wonderful place, but is it all downhill after Paris? I don't know.
Well, it's so different. But the good thing is that when I came back from Barcelona to Paris, I really realized how beautiful Paris was.
Mm-hmm. Right. Yeah, that's wonderful. Now, you still have family in Paris, right?
Sure.
Okay. Are you married, kids?
Yes, I'm not married, but my wife is a psychiatrist. I think it's something you find a lot. I have a lot of medical oncology friends whose wife is psychiatrist.
Really?
So it's quite funny. And we have one daughter. We have this special way of living because my wife and my daughter live in an island in France called Corsica. So it's the south of France. It's a very nice landscape. It's a very quiet place. And I travel each weekend there. So
Wow.
I work very hard during the week. And I'm completely off during the weekend. So it's drive. A lot of people say you are completely crazy. You will never live like that. And in fact, it's now a lot of my colleagues say, well, you're lucky because you don't have barriers to work during the week, but the weekend is completely for the family. So I never work during the weekend. I tend to say no to any invitation during weekend. This type of congress is the only waivers I have.
So you just partition your life so that when
Yes.
you're with them, you're there.
Exactly.
Yeah.
Exactly.
How old's your daughter?
13.
Oh, that's, I'd say a good age, but that's, at least my kids, especially my daughter at 13, was rolling her eyes and looking at the screen, and it's a lot of interest in their friends more than their parents.
Yes, but still we still share some
That's
good
nice.
things.
Is that a nice place for them to be?
Yes, it's not Barcelona, of course, but it's still near the sea. It's the same kind of weather. The food is amazing. It's a great place for wines. So,
Do you spend much time these days in a lab, in a translational setting, or are you focused in a clinical world?
no, mostly in the clinic. I have also some management responsibility, but it's mostly the clinic. I think my job is really to see patient, treat patient. This is really what I like to do, and to provide samples for the lab. So we have a lot of huge studies where you biopsy the patient, you take blood, and it feeds the lab. The lab gives back the results of for example, the whole exome analysis and RNA-seq, so that we have biomarkers to potentially treat the patients, put them in the phase 1 trial. So I think it's really my main role in the hospital. And then we have very, very close link to all these TR research teams. So we have meetings very on a regular basis.
I'm amazed at the depth and the amount of research that's being done at Institut Gustave Roussy, and a lot of novel trials. I mean, Jean-Charles was there, and it seems like a very impressive place to be working. Must be a magnet for lots and lots of patients to come.
Yes, it's a very nice place to work. I think patients might see this cancer center as a bit big at the beginning, but they very rapidly realize that because it's a cancer center, all the people that work here, but all the people have the same interest for people. All these people are really, they have serious disease, so I think the ambience of all the people that work here is different. So they might see at the beginning as a big place, and at the end they say, well, everybody is so kind here. So that's also something I like a lot in this place.
What led you into thoracic oncology? Was it your choice? Was it maybe working with Dr. Le Chevalier, who is, of course, a huge leader in the field? Or were you kind of directed into it because there was a need at the institution and you had mixed feelings?
So it was by chance. At the time, I was a fellow in oncology. Jean-Charles Soria was doing his PhD in MD Anderson, and he came back as an associate professor. And it happens that in France, each 6 months during your fellowship, you change the department and the hospital. So it's 5 years, and you have 10 different places where you will learn oncology, which is fantastic because you see all these teams that can work in a different way. And when Jean-Charles came back, I was intern in the same ward than Jean-Charles, so he was my +1 boss. and then we have started to work together, and then he offered me with Le Chevalier to be associated professor, and then this is how it happened. But it's mostly driven by Le Chevalier and Soria, clearly.
You've done a lot of pivotal work in lung cancer over the last few years, and a significant amount of that has been on the question of which patients benefit from immunotherapy, maybe which patients don't, which could even be harmed with hyperproliferative disease. Can we start just with a concept of hyperproliferative disease that certainly I'm familiar with, but I'm not sure all the listeners are. And if you could talk about what you've looked at, what you've found, and some of the open questions about hyperproliferative disease.
Well, the concept came from the phase 1 department. So Soria was the head at this time, and because they had this drug first, they saw that in some patients there might be some deleterious effect because a few patients had quite indolent disease, and when they received their immunotherapy, suddenly there was an explosion of the disease, and this is something that was hardly something you could link to the natural history of the disease. And it's not only lung, it's bladder, it's head and neck. So then they try to see what was the pace of the disease before. So you take 2 CT scans and you just measure the speed of the growth. So we call that the TGR, tumor growth rate. And you measure the speed before and after immunotherapy. So it's a very simple calculation between before and after. So there are various ratios. Soria used a very simple ratio. If the speed double or more, it's an hyperprogressive disease. They find 9% of hyperprogressive disease. Then an Italian fellow, Roberto Ferrara, very clever guy, came at Gustave Roussy, and I told Roberto, well, you will go to 8 different centers across France, so he spent 1 or 2 weeks in 8 different cities, and you will collect the data of these centers. So most of these centers it's run by friends that open their door to Roberto, and then he managed to collect the data of 400 plus patients, and we saw that the rate of HPD in these patients were 14%. He collected all the CT scans, so huge work, 3 CT scans per patient, baseline -1, baseline +1, and all these CT scans were reviewed by our radiologist, Caroline Caramella. She did an amazing job, so everything is really reviewed, centralized, let's say, and so we are quite confident of what we said. We did the RESIST evaluation, we set up a rule. It was all in the STAT database, and the STAT came back with this number. So we are completely clear that it's quite a pure setting. And then it was reproduced. There is a South Korea study just published where they have 230 patients, I think. They have a rate of HPD that is roughly 20%, and they apply 3 different definitions, and it's 20%. At the World Conference this year, 2019, there is again some work that shows that it's around 15-20%. So we are quite confident it's there. It's true in lung, it's true in head and neck, it's true in bladder. We have applied the definition to patients that receive single agent immunotherapy, like, I don't know, 3rd line docetaxel. And rate of HPD is only 5%. So we think it's really something related to HPD. There are strong believers in HPD. In Europe, Marina Garasino is also a strong believer. She has done very nice work in her lab showing that there might be an effect with the macrophages, but roughly we don't understand what drives this phenomenon. We don't understand how we can select the patient that should not receive the immunotherapy. Well, it's in an area we have a lot to learn. And it's a concern for the single agent immunotherapy, but now that we enter the area of chemo-IO, it seems that the chemo erase this deleterious effect. So it's quite safe now.
Yeah, and I could see how that would reduce the risk of hyperproliferative disease if you're adding another modality with a different mechanism of action. Does this concept enter into your mind if you have competing standards of care, like, say, a patient with a tumor PD-L1 of 50 or 60%, and you could give chemo and immunotherapy concurrently, you could give pembrolizumab alone. Are you inclined to strongly favor chemoimmunotherapy because of any concern that a patient will have hyperproliferative disease if we guessed wrong and missed their chance to benefit from chemo?
Well, I think we all had bad experiences with single agent immunotherapy up front with patients who really had difficult outcomes, let's say, on immunotherapy. So I like to say that what is published in the New England with immunotherapy is not exactly what you see in your real life. I remember this Italian colleague that screened 21 patients in Keynote 024, and she randomized only one patient out of 21 screened. For me, it's the best reflection how selected are the patients in Keynote 24. I mean, the results of Pembro here is amazing, but these patients clearly have indolent disease and probably tumor burden that is not that high, because you can't wait 1 month to be treated first line when you have an aggressive disease. And it's funny to see that in the same patients, same definition, the 50 plus PD-L1, in the Keynote 42, DOS is 22 months when it's 30 months in Keynote 24. So it's really reflect that this trial with single agent Pembro was in very selected population. So my take from that is that if a patient has a quite aggressive disease with a lot of symptoms, whatever the prescription of steroids of this kind of thing, it will be chemo-IO. If the disease is quite slow, it will be IO single agent, because tolerance is so great for IO single agent.
And my hope there is that if they do respond and you can spare them the chemotherapy and maybe have them do well for a very long time, terrific. You don't want to give the chemo and the maintenance pemetrexed if they don't actually need it all that time.
Exactly. Well, I'm still in love with chemo. Chemo works so well, whatever the mutation, whatever PD-L1, it's still an amazing treatment. So yes, you want to spare chemotherapy, but all these guys that say, well, I want a world without chemo, I said, well, the world with Nivo-EP can be sometimes quite challenging too. I mean, these talks can be very, very difficult. So,
and I also presume by some of the work you've done that you're not a believer that immunotherapy is going to work for every patient if we just give the right cocktail.
Exactly. So, and I'm also a believer of sequence. I think that overall survival is really the sum of the PFS. And my concern with chemo-IO upfront is that you give everything at the same time, and what is left for the second line. So, it's also a concern.
France has been among the global leaders in broadly testing patients for molecular markers. Has it gotten harder to do that now that we're entering into an era where it's not as clearly valuable to do individual tests for 3 or 4 markers. I know you've always been ahead of the curve, but if you need to do NGS now, and that takes weeks, is it working to broadly test all of the patients in France with NGS and have people wait on the results before starting any first-line treatment?
So what is offered now in France for any patient diagnosed with lung cancer is a quite nice NGS profile of 17 genes. This is what we do in lung cancer. So it covers most of the druggable alteration. Now, and I think you are one of the few that say, should we really do large comprehensive panel to everybody? It's so fashion to do large NGS, but what for? If you don't have drugs to match these targets, what is the goal? We have seen at this World Conference the results of the incredible Matrix trial in the UK. So it's a massive initiative with a large NGS, and then the results are not that good because they paired the targets and the existing drugs based on weak hypotheses. And people expect the addiction everywhere. So they expect what you see is EGFR, this pattern of the addiction, where usually the pattern of the addiction is less than 10% progressive disease when you give a drug. This is the pattern of the addiction. So it's EGFR, ALK, ROS1. And they expect that in all the targets, but no. So I think that 17 genes is really decent. I much more prefer to have 100% of the patients with 17 genes than a few selected with 500. And I will dig deep and deep and deep in light or never smoker. If I don't find a target in these patients, I'm too frustrated, so I will go wherever I can. So we have programs for these patients where they can access very broad molecular profile. But in a KRAS mutated NSCLC, EV smoker, well, immunotherapy is there. We should be reasonable, I think.
Well, I'm very much a believer that right now one of the biggest bottlenecks we face is delivering on what we already have broadly by executing far out in the world where all too often people aren't even getting tested for the targets we know are wildly effective. EGFR, ALK, ROS1, BRAF, and now a few more, like we've seen the data with RET and MET, and it is a growing subset, but it's still limited. And my concern about looking for more and more and more is that when you return a whole lot of garbage results in there, it just reduces the signal to noise ratio and makes it harder for people to understand what they're getting and deliver the treatment that they need because they're confused by 4 pages of garbage results.
I can't agree more. What we have done is that we have created the first molecular tumor board in France because you need brain around the tables to analyze. While you order let's say a commercial test, you receive these reports with all these suggestions, and sometimes the suggestions are a bit crazy, but it's written on the paper, and the patients paid $4,000 to get that. So they believe in that. Give me this. This company thinks it's a good thing. So we think that you need brains to say, it's a target, it's relevant, and you need a big phase 1 facility to bring drugs. In that setting, it makes sense to have broad profile. But in general, I fully agree that the issue is that there might be some physicians that say, oh, you don't do this broad panel with this kind of hair, or you really live in the third world, And this is awful because, well, there are really few targets that really will impact the overall survival of the patient.
Right. Thank you so much for taking the time. It's great talking to you.
Thank you, Jack.
Thanks for listening. The West Wind podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.